here behind the Batman building. So I hope I get to see you there if you want to come and visit us. I actually been trying to come to Seoul for many, many years. In our family, we love soccer, and it's a tradition in our family to go to World Cup. And 2002, we were actually set to come here. I got the game tickets and everything, and only when I was about to book the flights, my wife said, no, we have 2 boys. So she said, no, the boys is too young for such a long trip. So we canceled. But here I am, 23 years later, coming to Seoul for the first time. So I'm so happy I didn't give up on that. And by the way, this was probably one of the best World Cup organizations. So congratulations, 23 years later. These are my disclosures. So today we're going to talk a little bit about stem cell therapy and reproduction. I know we had an amazing session about cell therapy in general, but maybe we'll talk in the context of reproduction and what's unique about reproduction in terms of cell therapy. Then we'll talk about what we're doing specifically for these sets of conditions, which are really kind of a spectrum of the same pathology: premature ovarian insufficiency, low ovarian reserve, poor ovarian responders. And then for the second half of my talk, we'll really talk about our innovative work, about a novel, totally new concept towards fertility, what you can call fertility preservation. We actually like to call it fertility protection, mainly in the female, but also maybe a little bit on the male, and future directions. First, I'd like to give tribute to those 2 amazing postdoctoral fellows I mentioned a second ago, Dr. Han-Soo Park and Dr. Jin Sok. So they came to my lab a few years ago. They did an amazing job. I really wanted to keep them for as long as possible, but they love South Korea, so they are back, and I know they are doing great here now. So, and like I said, I'm very excited to meet them tomorrow. I haven't seen them for a long time. And a lot of the work I'm going to present today is actually the work of particularly Dr. Park, but also some of it is from Dr. Jin Sok. So, yeah, we heard a lot about mesenchymal stem cells in the last half an hour or so. And I know we saw a picture of an old phone, and we were told this is the mesenchymal stem cells, and the new phone, the Samsung Galaxy 7 and iPhone 16, that's the IPCs. That could be true for maybe some chronic conditions where you're really aiming for long-term cure, and with that you are willing to take some risks, because as we heard during the discussion, I think we had very good discussion at the end of last session about some safety issues with induced pluripotent stem cells, with IPCs. I think with the reproduction, when you're working close in the ovary or the testis or even the uterus, when you're working very close to the gametes, the eggs and the testis and so on, so you're really treating 2 individuals, the mother or the father in the male side, and the future generation, the future babies. So as a scientist, we really need to be super careful. Like, we have an extra layer of safety and high bar for safety. And I can assure you from the regulatory side, things like FDA or EDA in Europe and so on, they will also have a very high bar for safety. So MSCs, mesenchymal stem cells, are perfectly healthy, multipotent stem cells. I think for our reproductive disorders, the other thing unique also about our reproductive disorders, they are short-term. They are limited time. You need to do improvement to produce a fertilizable egg, a good quality egg, or a fertilizing sperm, or maybe improve the endometrium for a short window of implantation. We are not dealing with chronic years and years of gene delivery that you need. So that's another unique thing about our reproductive disorders. So I think MSCs for the present and the near future is really very well suited to help a lot of our patients achieve their goals and their dream of building a family. I'm sure IBCs with more improvement, more safety, quality control, and understanding of some of the safety concerns may have a place in the intermediate or distant future. So mesenchymal stem cells are amazing to inhibit inflammation. They are very strong, potent agents to reduce inflammation, and these are just some of the protein factors, cytokines. Also, they produce a lot of microRNAs that can do that. They are also very good in modulating immune cells. Again, moving them towards immune suppression or decreasing inflammation again. And again, these are some of the factors that mediate that. And also they are very good in inhibiting fibrosis, enhancing angiogenesis, and decreasing apoptosis. And these are some of the molecules that can do that. Also a lot of microRNA. I didn't include the microRNA here. So the MSCs are very good in that, and by doing all of these modulation of cell function, they can revive, they can regenerate tissue. And it turns out that you do most of this really by producing EVs, exosomes or extracellular vesicles, EVs. And they package all these good, important cytokines and microRNA in those EVs. So you will see in my work that I'm going to describe to you now, we started using stem cells mostly, I would say, from 2012 to just before COVID, maybe 2018 or so, 2019. But then since then, the last few years and from now on, we totally shifted to using MSCs, EVs, because most of the good effect, most of the regenerative effect of MSCs is mediated through their EVs. Also, EVs bring a higher safety level, and also they have some manufacturing advantages in terms of production, in terms of long-term storage, and being off-the-shelf product that you can use in clinical trials and eventually in clinical care. So we really been very interested in this condition, premature ovarian insufficiency, for many years, and again, these other conditions are probably a reduced or a minimal cases of POI. So I look at those all as the same spectrum of condition. So POI, obviously for this audience, we don't need to introduce it much. By definition, when an individual go into menopause, a woman go into menopause under the age of 40, it's not uncommon. Actually, the recent epidemiology in the US is about 3%. So unfortunately, the prevalence is increasing. Nobody knows why. Typically, we think of environmental factors, etc. But unfortunately, the prevalence is going up. Most of those have normal karyotypes. So it used to be called resistant ovary syndrome. And the reason we used to call it that is the ovary looks healthy. And even when we used to take biopsy many, many years ago, it looks fine, except we cannot stimulate it. There's already a lot of FSH in the patient anyway, but even if we try to stimulate it further, it doesn't respond. That's why it used to be called resistant ovary syndrome. Of course, the other causes of POI is when you have chromosomal issues, but that's beyond the discussion today. I don't need to tell you, it's such a difficult condition. At the moment, in the US, there's no treatment option except egg donation. This is a good, successful, good pregnancy rate for couples who wants to pursue that, but for many couples, that's not an option for either cultural reason, religious reason. Now I practice in the winter in Abu Dhabi. That's not an option. Egg donation is not allowed in Emirates and in many other countries. And also when I was seeing patients in Chicago, I still see a patient in Chicago in the summer, also in the Jewish religion. egg donation is not a viable option. So these patients really have no viable option to achieve their dream of having, building a family, which is a very difficult news to break to the family. The interesting thing, and really the basis why we're even trying stem cell therapy or stem cell-based therapy of POI is the follicles are there. When we used to do biopsy, you always see very fibrotic stroma, very ugly, inactive kind of situation, but the follicles are there, the primordial and even some primary follicles are there. They are just not stimulated, they are very dormant. And that's why stimulating these follicles is a viable strategy to try to treat POI. So we got into this really many, many years ago. So I don't know if you can see the date there, but this is 2010, and which means the work was done in the last several years because we had expertise in our team on gene therapy. Up to this point, I would argue, there was no even viable strategy to stimulate the ovary from within. What we thought, and we still pretty much, the way we think about the ovary, let's stimulate it externally. Let's just give the patient more hormones, more stimulation to stimulate the ovary externally. I would argue this probably was the first paper where there's an attempt to change the microenvironment inside the ovary by injecting stuff into the ovary, and that opened a new era. So we did this because at that time, if you remember, there was some papers coming from Finland, etc., about genes connected to POI. For example, a certain mutation in the FSH receptor, follicular stimulating hormone receptor, this paper in Cell from the Hohtanemi team in Turku University, etc. So we thought, okay, well, once we know the genes, gene therapy then will become a viable option. We can put the missing gene in an adenovirus, and myself and others in the team had a lot of experience in viral gene therapy, and then we can inject it into the ovary and treat those individuals. So we wanted first to see, can adenovirus, can viral gene therapy even infect cells in the ovary? Because there was no data. So we just put an adenovirus expressing a marker gene, it's called LAGZ, just give you a blue color, and we inject them into the mouse ovary, and we were really pleasantly surprised that it can infect almost all the cells. These are granulosa cells or follicular cells in a follicle, totally infected with adenovirus, and also even some stromal cells. First time we can show that adenovirus can infect various cell types in the ovary. So that was really encouraging, that maybe we can actually change the biology of the ovary from within by modulating the internal microenvironment. Unfortunately, there was no further discoveries in the genes connected to POI. As we all know, most of POI patients now, we don't know what's the genetic issue. So other than this mutation in the FSH receptor, there was no evolution or floodgate of genes connected to POI until now, 25 years later or 20 years later, unfortunately. So that's when we did the shift then to stem cells, because if we don't know the gene, we cannot do gene therapy. But MSCs really, by producing those hundreds of growth factors and microRNAs, can override the genetic defect even if we don't know the genetic defect. So we start to work using MSCs to treat POI, again, in animals obviously first, and the concept was always to inject the cells into the ovary. Some of the failed trials with MSCs that we heard about in the previous session is because we really asked MSCs to do too much. We delivered MSCs intravenous or systemically and asked them to treat strokes or diabetes, or like some systemic issues. If you cannot deliver MSCs or their EVs in very good concentration to have a robust biological effect into your organ of choice, you're not really going to have an appreciable biological change. The good news about our conditions, whether it's the ovary, the testis, or the uterus, they are accessible organ, and they are small organ, relatively small organ. That's why I think MSCs have a future in reproductive medicine. So the idea was to deliver MSCs to the ovary directly, and the idea is to revive the granulosa cells, and then the granulosa cells then will support folliculogenesis, and we're able to produce a fertilizable egg and improve fertility. So a lot of in vitro work, this is all published. We're talking now about 2012, 2013, so this is not recent, but I just wanted kind of chronologically to go through the history of this program. Initially we used the genetic model of POI, FSH receptor knockout, but to be really mimicking the human situation, we start to use chemotherapy-induced POI model. So basically we use a healthy C57 black mice. We inject them with 2 common ovarian toxic chemotherapeutic agent, busulfan, cyclophosphamide. We allow the model 2 weeks to develop, so the animal develop premature ovarian insufficiency, and then we start treated by intra-ovarian injection of healthy human mesenchymal stem cells. I want to stress, we used healthy human mesenchymal stem cells. We always got those. We initially used bone marrow driven MSCs. Later on, we shifted to umbilical cord MSCs, but we always got the bone marrow from young females with proven fertility. So somebody who already had children normally, and they are willing to donate bone marrow aspiration. And then we evaluate all reproductive and fertility profile of the animals. Again, I'm just gonna kind of browse through this because this is all published. The bottom line, we got very good results. So here, for example, this is the healthy animals without chemotherapy as a positive control, and then the POI model with chemotherapy, just treated with normal saline with a vehicle, and then the animals treated with the MSCs by direct intra-ovarian injection. We looked at many markers. Here, we looked at the follicular stimulating hormone receptor. I know it's very small, so you might not see it on the back, but you can see here very good expression of the FSH receptor in the follicles where it should be, while in the untreated model, there's minimal expression. There's the AMH protein itself, and then we also stained for AMH receptor. Again, very healthy amount of expression in the treated group, really becoming similar to the healthy control, but much more than the untreated, inhibin A and inhibin B. And we looked at a long range of molecular markers for folliculogenesis. And this is just a histology of the ovary. You can really appreciate the difference. This is a nice, healthy, maybe this is better, a bigger magnification. Nice, healthy ovary, folliculogenesis is going well. This is the healthy control. And the treated animals start to look similar to that. Nice organization of the follicles, very nice, healthy follicles. While the untreated, just extensive fibrosis, minimal angiogenesis. Here also, this is a marker for angiogenesis. Again, minimal angiogenesis here, while in the treated, there's a good amount of angiogenesis. Apoptosis, tunnel assay, the opposite. A lot of apoptosis in the untreated animals, while minimal apoptosis in the healthy and the treated. So everything looks good. How about the function, the actual fertility markers? So we looked at the number of follicles. We see significant increase in number of follicles. Clearly not all the way to the normal, untreated, like animals that have never seen chemotherapy, but definitely much better than the untreated control. And then the pregnancy, the number of pregnancy was almost as good the untreated healthy control, and way better than the untreated animals. So it seems to be working. And in our team, we're very translational. Once we have a good result in the lab, we always try to translate it to the clinic very quickly. So we're talking now 2013, 2014. We started to engage the FDA right away. And of course, the FDA started to come back with unexpected questions that you didn't think about as a biologist, because some of the question actually doesn't make sense. So first they asked, well, how long will the stem cells stay in the system? So we took advantage of, we're using human MSCs, so we used marker for human DNA, basically the allo DNA repeats, and we track those in different organs. in the animals for as long as we could, about 90 days. And you can see here, the MSCs actually doesn't stay in vivo for long, or at least the human DNA. Probably around 3 weeks at the most, and then it disappears. And even during those 3 weeks, they stay only, we can detect them only in the ovary. They don't go anywhere else, which is a good safety thing. And the fact that your treatment, in this case the cell line, or the cells, doesn't stay in, that's actually a good safety feature for the FDA. And that's especially when you're treating, again, a reproductive organ. And then we did some in vivo tracking. We labeled the MSCs, then we tracked them. This video almost never works, but I can tell you it only stays in the ovary. It doesn't go anywhere else. And also they wanted us to try to inject intravenous, again, to look at safety. In case the cells leak into other organ, will they have any negative effect? So we did this experiment mainly for the FDA, and there was a very good safety feature. So by that time, we continued this work, but they kept asking for more safety, and also they wanted us to test other cell lines. They felt now from the ethical side, you know, the source of the bone marrow, it's an invasive procedure and so on. And actually there was increasing literature showing that the umbilical cord stem cells, MSCs, might actually be more potent than the bone marrow. So we did head-to-head comparison. Jen Sok actually did this work, and we also compared to fat tissue MSCs and so on. And at least for our purpose, the umbilical cord stem cells seems to be the most effective. So we shifted all our work to umbilical cord stem cells. Clearly, we get this from the wharton jelly, again, from a mother with proven fertility and a healthy mother with normal pregnancy, spontaneous pregnancy, and so on. And we repeated similar work, and we got very good results. So this is just an example of those experiments. Again, the left side is the healthy control, and then untreated, just chemotherapy. And then the right group is the group with the chemotherapy and the umbilical cord stem cells injected directly into the ovary. And as you can see here, for example, here we're looking at the FSH level in the blood, very high level in the untreated, as expected, while low level in the treated groups and the healthy control. Even AMH, I was really encouraged when I saw that we can actually increase AMH level. So again, here's serum AMH level. Again, healthy control obviously have good healthy amount of AMH. The untreated have minimal AMH, but then with the treatment you can increase that, which means that you are actually able to support the primordial and the primary follicular environment in these animals. And these are the number of follicles, all the different kind of follicles, from primordial all the way to antral follicles go up with the treatment, and of course the fertility also was improved. So after all of this, the FDA said, you convinced us, looks good, but we want you first to do autologous. So I told you, all the work we have done so far is with a healthy donor, with the allogeneic MSCs. MSCs we get from a healthy donor, we used it in the mice, and that's really the cells that we wanted to put in patients, because we were concerned that the patient with POI, especially idiopathic POI, it might be a systemic disease, so their own stem cells also might be defected, especially that we don't know the genetic defect in most of those patients. But because we're now talking about 2014, 2015, I know the paper came 2020, but the work started many years before. There was no other data available, so they said, this is all new, we want you to start with autologous. And just to keep pushing the field forward, we agreed, so we did the ROSE1 study, basically, and all the details, of course, is on clinicaltrial.gov. Basically, the patient would come in, we would do bone marrow aspiration in the operating room, and then we very quickly, using this machine, isolate the stem cells, and then they also wanted us to inject the ovary under vision, like during laparoscopy, not under ultrasound guidance, which what we really wanted to do. So as you can see, there's very high level of concern when you're doing something, you know, for the first time. So we do laparoscopy, we inject only the right ovary, and then we injected about 4 mil of stem cells, probably around 200 million stem cells, bone marrow MSCs, and then we inject also 4 mil of normal saline in the left ovary. So we did this, and we wanted to at least collect some safety data. This is just a picture of one of those cases. Those were very severe POI cases. Several years of amenorrhea, FSH in the hundreds, 3 digits, very severe cases of POI. So as you can imagine, the ovaries were very atrophic. The ovary was about a centimeter size. And then we injected, and you can see the ovary getting swollen. We inject very slowly, etc., and so on. So in terms of safety, it went very well. We did ultrasound 3 months, 6 months, and we followed the patient for a year. You can see with the Doppler some increased angiogenesis, increased blood flow. The right ovary stay actually big in size, suggesting probably increased angiogenesis, probably some activities, while the left ovary injected with saline become very small again. However, we got 0 pregnancy. And I personally wasn't surprised. It was just kind of heartbreaking for the patient to tell them that this is kind of the first step in a long journey for the patient. This is her journey. It's not just part of a journey. So the good news, the estrogen went up. Most of these menopausal symptoms, because as you know, these women are in premature menopause. We use the North American Menopausal Society questionnaire, the standardized questionnaire for menopausal symptoms. They got better in terms of menopausal symptoms because their estrogen actually went up, but we got 0 pregnancy. While we're doing this, we also shifted to exosomes. We basically repeated everything I showed you so far, but using umbilical cord, MSCs, EVs. And we got very similar results. This is one of the papers from Dr. Park and his team in our group showing very similar results. Again, similar design, except we inject the EVs in the ovary instead of injecting the stem cells. And I already touched like why we did that. There's many manufacturing advantages to shift and to use EVs. And also the cost come dramatically down. So here's the healthy control in terms of pregnancy rate. The POI in this particular experiment got 0 pregnancy. Sometimes you get minimal pregnancy in one mouse or something. While the group treated with the EVs, they showed very good pregnancy rate. And the pups also, we start to look at the safety of the pups and follow their growth. And the pups are always healthy coming out of these experiments. So again, very quickly, we wanted to translate. We provided tons of safety data to the FDA. Finally, about 2 years ago, we got the first IND approval in the US for a proof of concept study to evaluate rejuvenation of the ovary. I called it ROSE 2 because the first one was ROSE 1, rejuvenation of the ovary using stem cells, using exosomes from human placental, we call it human placental stem cells. So we got that. Although we got this 2 years ago, we just started, for logistic reason, we just started doing it a few months ago, and so far we have done 4 cases. We got very good embryos in liquid nitrogen now. We haven't implanted them, so we don't have any pregnancy data yet. So I'm hoping next time in here I'll have more data on those patients. I just want to show this. Of course, now we do the ovarian injection under ultrasound. So I have many videos of those, but I didn't think those are exciting. But I want to show a video. So everything I've showed you on the female side, we're also doing in the male side with males with azoospermia, non-obstructive azoospermia, because of testicular failure, primary testicular failure. Exactly the same results we got there and the publications, so you can please look at those. We also got approval to do the same in the male by direct injection into the testis. So this video showing one, hopefully it will work. Okay. Okay. We tested that before. I think once I go to the slideshow, okay, I don't have to be in a slideshow. When I go to the slideshow, it doesn't work for some reason. But anyway, So here is, okay. It started to work, then stopped. Okay, you know, I have another way to show you because I have it on my desktop. No, don't worry about it. I have it here. I think this one should work. So basically, I think I'm the only gynecologist who managed to get privilege to inject the testis. I got trained in animals, and we found with our help from andrologists, it's working now. It's working. Oh, it's not showing. Oh. Okay. Right, I had to apply for privilege for that because what in the ovary we actually inject in the center of the ovary under ultrasound guidance. We go with the needle in the center of the ovary and we deliver typically again around 3 to 4 mil of exosomes. In the testis, after the work we did in the animals and so on, we found, and also talking to the andrologist collaborators in our team, we found out that you get much better distribution when you inject in what they call tunica vaginalis, which is the top part of the testis. So you actually don't go in the body of the testis. So that's what I'm doing in this video. It's a very short video, but I think you probably would like to see it. Okay. Right. So you see, I know there's a lot of glaring. This is patient under conscious sedation, just local anesthetic on the scrotum. We made a tiny incision in scrotum, and you can see here, this is the tunica vaginalis. You can see my pointer. Yeah, so this is the testis right here, and we inject in the tunica vaginalis up here, and again, we're able to inject about 3 ml. Can we play it again? Or it's a one-time shot? Is that the reason it's not playing? Right. So this is just the top part of the testis and so on. So in terms of safety, we have done 3 cases so far in terms of safety. It's fantastic. This was about 3 months ago, the most recent just a couple of weeks ago. So we don't have any efficacy data yet. The andrologist told me we're not going to test the semen until 6 months later for each patient. That's how long it takes. They know more about this than me. But in terms of safety, it's fantastic. And also, they actually think, for the first 2 patients, the size of the testis looks or feels encouraging. So,
I was going to ask about what kind of MSC?
No, this is all off the shelf. This is umbilical cord, but this one is actually from a male baby. Umbilical cord, MSCs, the EVs from umbilical cord and MCs. This is all off the shelf. You just take them out of liquid nitrogen, you thaw them. And that's really the great thing about this allogenic approach. In terms of logistic, and the cost, of course, comes down. So this is not autologous. This is all off-the-shelf allogenic MSCs. So now we will shift gear, if I can get my slides back. Okay, perfect. All right, so let's, well, now it works. Okay, right, so now we'll shift. So this was all fertility restoration, meaning the patient comes to you, unfortunately, she has already developed ovarian failure or testicular failure on the male side, and you're trying to help them. How about the protection side? And I know in the next presentation, Dr. Osaga will talk to us in details about fertility preservation, but of course, you know this probably better than me. So when the patient have cancer, she has beautiful ovaries, beautiful testes, He has beautiful testes, but we know these are going to be damaged in the next few weeks when they have chemotherapy. Can we do something to protect them for their future fertility? And that's when oncofertility was born, and I'm proud that this concept was born in Chicago many years ago, about 30 years ago or so. And it has developed quite a bit. So at least for the female side, we have many options. We we can freeze embryos, we can freeze eggs, but each one of those approaches come with its own limitation. Egg freezing, embryo freezing takes time. And the utilization of the different methods of fertility preservation in the US in the female, it's about 3%. So out of each 100 patients who could be a good candidate for fertility preservation, only 3 say yes. The main reason is the delay, or at least one of the reasons, because they are eager to start chemotherapy. They don't want to wait 3 weeks, 4 weeks, and so on. There's other challenges. For example, if they have hormonal dependent cancer, they also don't like to increase the estrogen level in their body and so on. But at least this is a viable option. For young girls, the main option is fertility preservation is ovarian tissue cryopreservation. Again, this is a viable option. In about 20, 25 years, only about 200 babies have been born with this technique globally. Every country. Can you imagine globally only 200? Because, again, the success rate is limited, the graft life is limited, and there's other technical challenges. But again, at least there is an option. On the male side, the adult is semen freezing. It's very easy, non-invasive, very simple, inexpensive. Again, utilization is limited, unfortunately. But for the young boys with cancer, to preserve their future fertility, there's 0 options at this point. Not a single baby has been born for preserving testicular tissue. Kyle Orwig, University of Pittsburgh, and others trying to preserve testicular tissue and do isolate stem cells, etc., but so far has been unsuccessful. So I would say the options are limited. That's why this cat is kind of sad. So in our team, we thought maybe the stem cells actually might have a role in this. And the concept there is very simple, that to expose, in the female side, the granulosa cells to MSC's exosomes before they are exposed to chemotherapy. Most of the damage that happens to the ovary is granulosa cell, the testis is Sertoli cells, because these are the rapidly proliferating cells in the gonads. So that's where really most of the damage happens when the patient receives chemotherapy. So the question we put forward, can MSC's EVs provide some protection to these cells while the chemotherapy is doing its job of killing the cancer, and then after that, these cells will be kept healthy so they can provide their function. Some of the data I'm going to show you quickly because of the time factor actually show that yes, this actually is a viable option. So we exposed granulosa cells, and we did exactly the same on the male side with Sertoli cells to EV, and then we exposed them to chemotherapy. Here's the healthy control. For example, here we looked at apoptosis, caspase 3, minimal apoptosis in the healthy without chemotherapy. Those with chemotherapy, of course, a lot of apoptosis, but those protected. FB means fertility protection with EVs from MSCs and minimal apoptosis. DNA damage with gamma H2X. No DNA damage, a lot of DNA damage when you don't have the protection. When you have the protection, you have minimal DNA damage. And then we think the mechanism of action is that EVs actually upregulate this group of genes. It's called the APC membrane effector transporters. Things like PCR1, MDR1, the multiple drug resistant gene 1, etc. It's a long family of genes. Their main job is to take any toxins, including chemotherapy in this case, from inside the cell and just get rid of it, or prevent it from coming in the first place. Here we show that the EV's stimulation actually upregulate this group of genes, and we think it actually prevent the chemotherapy from getting into the follicular cells in the ovary, the granulosa cell, or the Sertoli cell. So I'm going to fast forward a little bit. to cover the highlights of this approach. So we did very similar work to what I showed you before, except this time we inject the EVs first into the ovary, then expose the animal to chemotherapy, just really to mimic what we think might be the future clinical trial. The patient have cancer, we will inject the EVs into the ovary or the testis before they get the chemotherapy, maybe the night before, and then next day they will get the chemotherapy. And the idea is that the ovary or the testis will be protected. And then we followed the animals, and then we evaluated fertility, and we got very good results. Here's the healthy control, good fertility, good pregnancy rate. Those without a protection, again, they develop POI, so minimal fertility, while those which have been protected by the EVs, they showed very good pregnancy rate. Again, not as good as the healthy control, but significantly better than the untreated. And again, the number of pups reflected that. The pups looked healthy, and here's some pictures. Again, this is the normal ovary. The unprotected ovary basically develop POI, while the protected ovary have good folliculogenesis, good size, and here's the AMH level. Again, we're able to maintain almost close to normal range of AMH level. And we looked at fibrosis, apoptosis, they all seems to be maintained. And this is the expression of, again, the ABC transmember transporter, because this is, we think, is the mechanism of action, and we looked at other members of that family, and again, the MSCs, EVs, overexpress the expression of those genes, and we think that's how the ovary is protected, and we have similar data in the testis as well. And because of that, the gonads are able to be maintained, and the DNA damage is kept minimal. So here's the DNA damage in the ovary. This is now in vivo, so we're looking at the whole ovary, extensive DNA damage in the unprotected ovary, while minimal DNA damage in the protected ovary. Again, very quickly, communicated with the FDA to start a phase 1 trial in young boys and girls with lymphoma. They wanted human safety data. So how are we going to get you human safety data? Before we actually do the trial, they said, well, you can use tissue. So we start to collect normal ovarian tissue from patient coming, for example, for tubal ligation or benign gynecologic condition. So this is now a couple of slides on human ovarian tissue ex vivo. So we bring them to the lab, we maintain them in the lab in sort of kind of ex vivo culture for about 48 hours, and then we do the same thing. We inject them with EVs first, and then expose them to chemotherapy. Here is the unprotected, extensive apoptosis, while the human ovarian tissue with AVs, minimal apoptosis. And we also looked at other genetic markers. So the proposal for the phase 1/2A trial, and we think that can really help the field, is patient with a cancer diagnosis will come in, get direct intra-ovarian injection or interstitial injection in the boys, in the female under ultrasound guidance, and then the male, just like I showed you. But then the advantage is they can start chemotherapy the next morning. So there is no delay. And we think this really can increase the utilization of fertility protection, because the delay, when we ask the patient, the delaying of the chemotherapy is the #1 factor why they don't consider fertility preservation. Hopefully the patient survive her cancer or his cancer, and then they will have functioning ovarian tissue or functioning testicular tissue for both fertility but also for hormonal production. So they might not need external hormonal supplement, which they do now. So I'm not going to take too much time. I don't want to go over time. We did very similar work on the female side. In the male side, very similar results. And actually in the male, you can see here the testosterone level. Here's the serum testosterone level. With the protected testis, they continue to produce high level of testosterone for up to 90 days after 1 injection. And we did 2 and 3 cycles of breeding, and you can see here the unprotected animals are infertile, while the protected animals continue to produce pups up to 3 cycles, which in the animals about 90 days after just one injection. So I'm really excited about this, and I think there is a place for MSCs, EVs in reproductive disorder. So this is POI and related disorder. We are in phase 1, 2A, and I hope to come back with more human data in the future. We also about to start, we got the approval in collaboration with Mary Madeleine Dolmans in Belgium to do a phase 1, 2A trial in young boys and girls with lymphomas. And we think really, and we have some preliminary data and maybe a couple of publications in PCOS about using a similar approach. So I think actually MSCs have a role to play in reproductive medicine and to help a lot of our women now and in the near future, while maybe the promise of IBCs might help long term. Thank you so much.